Hello everyone, welcome to my YouTube channel. Today we're going to be discussing further with what I had already discussed about MHRA blood bank guidelines. So there are two things that I mentioned. Then I mentioned about electronic issue and I mentioned about IT. They are all related, remember, because we cannot necessarily do electronic issue without IT services. So that is why they are together. In fact, there's a way, if you look at it, you might just be looking at electronic issue in general. But today I'm going to be more specific in what I had already discussed before. So I did give you guys overview about MHRA blood bank guidelines. So if you've not watched the video, you can watch it. So today we're going to be looking at the guidelines MHRA in working together with BCSH to come up with something, what they are expected in terms of electronic issue. So what it means then, if you do go for interview, they ask you something about MHRA guidelines, you can pick some of these things that I'm going to be saying today. So once again, my name is Dr. Emmanuel Obodo. I've been working in the UK as a specialist biomedical scientist, and I'm a lecturer in biomedical science here in the United Kingdom. Okay, so now let's move into it. So the guideline we're looking at today is MHRA electronic issue guideline. Remember that I did say that these guidelines, they work together with BCSH guidelines, so they are all the same. So now in electronic issue, I'd already told you guys that everything has to be automated. In the analyzer, when you load the materials such as the card grouping or IgG card or the reagent that you're loading, whether it is A1 cell or B cells or antibody screening cells, whatever materials that is being used to process that patient sample, once you load it in the analyzer needs to scan the barcode and recognize it. Meaning that in talking about electronic issue, you have to make sure that everything has to be automated. So meaning the reagent has to be automatically identified, the patient's name and identity has to be automatically identified, the result, once the analyzer finished processing it, the result has to be automatically interpreted, okay? And of course, the sample testing itself, the analyzer will have to dispense the sample on its own. So what does that mean? So when the analyzer is processing it, it has to do all the dispensing. You are not the one doing the dispensing. You are not the one doing the dilution. The analyzer will have to do everything. Now, once the analyzer finish analyzing it, and you see the result and you are happy, the analyzer should be able to transfer the result to the LIMS. So meaning, again, there is no manual input. So the first guideline of electronic issue is automated testing. So in that automated testing, the patient identification, the reagent or the materials, the result interpretation and dispensing of the sample has to be automated. And this is vital, like I've said previously, in MHRA inspection. Another thing that MHRA mentioned, there has to be automated pre-transfusion record, which of course has to be whether it is electronic issue or it requires serological cross-match. What does that mean? What it means is that before a patient can be transfused, whether you are using electronic issue, whether it requires serological cross-match, it doesn't matter on this occasion. But you need the LIMS to be able to know the patient detail, remember? So you have to know the patient detail. That will tell you the patient group, okay, if the person has a historic group or does the person have a current group. Then you also have to know, of course, the age of the patient. Every detail regarding the patient, you should be able to know that, okay? So whether the person has a historic antibody, everything has to be automated on the LIMS, okay? The LIMS that the hospital is using. Meaning for the ones who are using telepath, you see it on telepath. If you are using lab center, you see it on lab center. Or Meditech, you see it on Meditech. So you use this lab LIMS to be able to see the patient details. So from there too, you can have something like reaction pattern. Now when it comes to the testing, whether you are testing manually or whether you are testing using analyzer, which is automated testing, there has to be a record of the reaction pattern of ABO and antibody screening record. In other words, when you do the blood group and antibody screening, you are going to see that different patients have different reaction pattern. So you see some people that have something like, depending on where the reaction may occur, you might see something like 2 pluses, you might see 1 plus. You might see 3 pluses, you might see 4 pluses. So you cannot just say this person is A positive. For you to interpret that result, you must give us the reaction pattern. Remember what I told you guys about weak and partial D. So it's from this kind of reaction that you can be able to know whether you're going to investigate for partial D or weak D. Meaning that you have to tell us what is the reaction on anti-A, what is the reaction on anti-B, what is the reaction on anti-D, what is even the reverse reaction, what is the reaction on anti-A, what is the reaction on anti-B, and of course the antibody screening, what is also the reaction pattern, what is the plus, what is the strength, what is the degree of the reaction. Remember, we are still talking about pre-transfusion record. So in that pre-transfusion record, apart from the patient detail that you've seen, I'm saying now that the reaction pattern, when you test for that patient sample, the reaction pattern, we need to see the reaction pattern. Whether it is manually documented, whether it is automated documented, we want to see there has to be a reaction pattern before you can be able to interpret a patient result. And this reaction pattern, you have to return it. Remember that when MHRA come, they are going to be asking you for these things, okay? So when they come, they expect that this reaction pattern, that you return it. So you can return the reaction pattern on the LIMS, the laboratory information management system, you can return it there. So, and also you can return the reaction on the analyzer. You can also have a worksheet, which people may call something like lab book. So you need to have a lab book or a worksheet where you keep record of this reaction pattern. Now, let me help some of you guys that may not be working, that have not worked in the UK. Let me give you this idea. I told you guys previously that some hospital does not have analyzer, so no patient there is eligible for electronic cross-match, which is electronic issue. But remember that every hospital have LIMS. What I mean that they can also keep, even if they don't have analyzer, they have LIMS where they can transfer the result that they obtain manually. They will just transfer it into that LIMS, okay? Meaning that these reaction patterns, you can keep the reaction pattern on the LIMS, you can keep it on the analyzer, you can also have a worksheet where you keep it. Why? Because when MHRA comes, you need to show them, this is what I've done, this is where I keep the result, this is they want to see the reaction strength that make you say that this is A positive or B positive or AB, whatever group that you may have given to that patient. They want to see the detail of the reaction, and they want to see that you've kept this information. Let me also say this. So when you go to this hospital that does not have analyzer, what happens is when they finish manual testing, they will manually input it on the LIMS. So I'm saying that this automated pre-transfusion record, okay, we want to see the reaction pattern of the ABO grouping and also antibody screening, and also want to see that you return this information using the LIMS or using the analyzer or using the worksheet. Okay, I hope that is clear. The next point is still on the pre-transfusion record, automated pre-transfusion record. So I've given you guys about what happened in terms of automated testing, but also when it comes to the manual testing, which I already started saying, when it comes to the manual testing, it will require two people. So if one person has manually tested the patient blood group and antibody screening, another person will have to confirm it. You see it now, before that result can be reported on the LIMS. You see it now, and the first person testing and the second person testing will have to agree before it can be reported. So when it comes to the manual testing, it has to be independently reviewed. Okay, so that is another guideline from MHRA. I hope you are getting this. Okay. And the whole idea of this is to avoid the risk of mistake, because it's manually tested. So if I make a mistake in my manual testing and I say that someone who is B positive is O positive, that will be a problem. But if I make that mistake and another person tests it, the person can pick it up. You see it now. So then that will not prompt me to retest it to be able to confirm. So these are very, very vital. So the MHRA put that policy in place to make sure that this risk, this possibility of maybe giving a wrong result or reporting a wrong result, will not occur. Okay, that means this has to happen before issuing any blood product. And what it means, because it is manual testing, don't forget the person is no longer eligible for electronic cross-match. That means there has to be serological cross-match. In other words, so because of the risk of the manual testing, you then have to treat it in a way that can measure up with the risk. And the way that it can measure up with the risk of the manual testing is that you must do a serological cross-match. You see it now. Unlike automated testing, where if everything is fine, we can do electronic issue. But in manual testing, even if the person has a current group, has no history of antibody, the person is not eligible for electronic issue because it's a manual testing. So that risk, the way to measure up with that risk is to make sure you always do serological cross-match. So what did MHRA say? That where there is a manual testing, in other words, where there is no automated testing but manual testing, it has to be independently reviewed by maybe 2 members of staff, as the case may be, okay, and this will help to avoid the risk. And of course, there has to be a serological cross-match because that will measure up with the risk. I hope that makes sense, yeah? ABO typing is another thing that MHRA put in place. Let me say this before I continue. In this ABO typing, okay, or resource typing, whichever one that is best for you, I want to start by saying what makes a blood group positive. We have blood group A, we have blood group B, we have AB, we have O. So when you say that someone is blood group A positive, what you are saying that the person D antigen is positive. Both A positive and A negative, and they have antigen A and antibody B. You see it now. That is what 2 of them have. Blood group B positive and B negative, both of them, they have antigen B and antibody A. 2 of them have it. What that separates positive blood group and negative blood group is the D antigen. MHRA want to make sure that the D antigen is determined because it's a paramount in blood transfusion. So anyway, the next guideline is about ABO antigen typing, and that means that this very D antigen must be determined. It doesn't matter whether you are doing electronic issue or whether you are doing serological cross-match. Irrespective of any method of testing, you must make sure that you have determined the D antigen of this patient before issuing any blood product. And how can you determine this? You have to confirm this by repeating the test. So let me explain this, because it seems generic here. So when it is manual testing, of course, they have to test it twice. That's the way of repeating it, okay? Remember that we've talked about electronic issue. There has to be a historic blood group. So when you do the current blood group and it's still confirmed that this person has D antigen or does not have D antigen, that is a way of confirming it. So when we talk about that the person must have a historic and a current group, this is a way of confirming it. So MHRA is saying that for the D antigen, since it's a paramount in the transfusion, in the blood transfusion, you need to make sure that this D antigen typing is confirmed by repeating the test. And that repeating testing, like I've said, can be from maybe when we talk about historic blood group and also current blood group. That is okay. But when we talk about the manual testing, even if the person has a historic blood group, in the manual testing, it has to be done twice. You see it now. So, sometimes a patient might come to the hospital and we don't know this patient, okay? This is the first time this patient is visiting this hospital. So we don't have a historic group. We don't have a current group, of course. So what we're going to do then, we make sure we tell the ward to please, if they want to transfer this patient, we tell them, please make sure you collect the sample. Collect 2 samples, and it should be collected from 2 different members of staff, and it should be collected at least 10 minutes apart. You see it now. That means they will send it, you have these 2 samples in the lab from the same patient, collected from different staff, okay, at different time, at least 10 minutes apart, okay. Now, once you test it, once the first sample sent and the second sample sent agree, that is another way of confirming the blood group of that patient. So this is just to make sure that we know that the D antigen of this patient has been confirmed. So if you have only 1 sample, okay, if the ward is not able to provide you the second sample, if you have only 1 sample, that means you have to test it by 2 different methods. So you have to test it by a particular reagent, then also have to test it by another reagent that has a different clone. Anyway, what I'm trying to say that ABO typing is another guideline that MHRA is saying you must confirm the ABO typing of the patient. Meaning, it's not enough to say that this person is a blood group. We want to know, is it positive or is it negative? So ABO typing of a patient must be confirmed. Now, another guideline, which some of this I've already touched it, okay, but I'm happy to follow it this way. Another guideline is when you have a first patient, new patient. Okay, I've already said, so you don't know this patient, you don't have a history, you don't have a historic blood group, rather you don't know this patient. So that means you need 2 samples, and these samples must be tested both the forward and the reverse grouping. So that's what MHRA is saying, that in testing for a patient, especially for the first time, you must test both for the forward and the reverse grouping. Very, very vital. Now let me tell you what I mean by this. Sometimes when we already have a historic group, automated, okay? Or even if it is not automated, when we already have a history group, sometimes in a case of emergency, you may just need to do a rapid group. That means you may not need to do a reverse group. You can just do the forward group, then provide the blood, okay? Because you already have a history group. Anyway, MHRA is saying for the first time of testing the sample, you must test for forward and reverse group. Very, very vital. So this is irrespective of the method, whether it is manual or automated. And of course, you have to use a verified reagent. Remember, we'll talk about reagent verification to be able to do this testing, okay? Remember, why I keep saying this, because MHRA will ask for this evidence, and that is why they are putting the guideline in place. To summarize this very particular guideline, if it's the first time the patient is coming to that lab, you have to do both the forward and the reverse group. The next guideline is about delivery and test method. Now, what MHRA is saying in delivering and test method is that they say that there has to be a procedure in place to be able to receive any materials that is delivered in the lab. Why is it important? It is important because the manufacturer may have changed their instruction from the previous delivery. That is why whoever that is receiving that sample must take note of the delivery, okay, the material, the information on the delivery to make sure that nothing has changed. Let me give you guys an example. Very, very important. Let's say you are getting something like antibody screening cells, okay? Now, the manufacturer might tell you that on cell 1, there's the antigen K, there's antigen C, there's antigen D. They may say that, okay? Now, on cell number 2, they may mention another thing, but the next delivery, there could be change on the cell 1 antigens. The antigen K that was on cell 1, on the next delivery, it may be on cell number 2 or cell number 3, as the case may be. So that is why it is important when you receive a product that you check everything from the previous delivery to make sure that nothing has changed. That helps you to pay detailed attention on what you are expecting and what not you are expecting, okay? And that will minimize error. You see it now. Another guideline is about the test method. So the test method is that you have to make sure that you control your test method to make sure that any possible error will be detected. For example, things like pipetting, especially in the manual testing, you have to make sure that members of staff are correctly trained, okay, so that their pipetting skill will be good, because the strength of the reaction pattern, we'll mention about the reaction pattern. The strength of the reaction pattern may differ from one staff to another. Maybe another member of staff, because of the pipetting skills, might have 3 pluses. You see it now. The second, another person may do it and have 2 pluses. Why? Maybe it might be because the volume of the sample added may be more or less, depending as the case may be. That is why they want you to control your test method in such a way that any possible error will be detected. Another guideline is about transcription. So remember that once you finish testing, that result will have to be transferred. You see it now. It has to be transferred to the LEMS. So now the MHRA, in trying to avoid transcription error, remember that each of these guidelines is trying to avoid error. The guideline that I will be mentioning, even the future guidelines I'm going to be talking to you guys about, everything is trying to avoid error. That is the whole essence of a guideline. All for the benefit of the lab users, such as the patient, okay? Now, so in trying to avoid transcription error, the guideline is that before transfusing a patient, there has to be automated transfer of the patient result to the LEMS. But in some cases, like we said in the manual testing, that is not possible because there's no any automation, there's no any analyzer. So in the manual testing, 2 different staff have tested this, like I've said. So when they finish testing it, this one will put the result, the other one will put the result, okay? When they finish putting the result in the LEMS, they also someone have to double check it again. In other words, when you put the result, there's what we call perform and validate, okay? I can manually put a patient result on the LEMS, but I will perform it. In other words, I have not validated it, okay? So another member of staff will come and check it. Once that member of staff check what I have done, look at everything I've done, and everything appear okay, the person will have to, double check it with what the person is seeing on the worksheet. Remember, it was done manually, okay? So the person will double check what I've done on the worksheet and what I've put on the LEMS. Once everything tallies, the person will validate it. Meaning that once you are inputting any result manually on the LEMS, it has to involve 2 members of staff. 2 members of staff has to be involved. One person will have to put it first to perform it, and another person will have to double check it to be able to validate it. That is what MHRA said. So that's why, in order to avoid this very transcription error, they strongly advise that there should be independent verification. And I did say sometimes, depending, think about when you are working at night and you are the only person. So what it means that there's nobody else that can check what you've done. So there's what we call blind verification or blind entering of the result. Okay. So what happens that you can check yourself. You manually put in the result. Okay. Then you also log back on to check what you have done. So you are the one doing the second verification now. You can do that when you don't have another member of staff to be able to double check what you've done. Okay. So what it means that you put in the result, then you also log in again to also confirm what you've done. Okay. Again, tallying everything with your worksheet to make sure that what you've typed in is correct. So that is to reduce the transcription error. Okay. And of course, this has to happen before issuing any blood. MHRA came together with BCSH guidelines. Strongly recommend electronic issue, remember? Now, they say that where electronic issue is performed, it has to be strictly adhere to the BCSH guidelines. And there's a guideline that BCSH stated in terms of electronic issue. Most of them we've mentioned, okay? There should not be any manual input. Everything has to be automated done. So they are the things we've been saying so far anyway. So that means it has to be strictly adhered. And what it then means, in addition to what we've said already, is this. The way to determine whether the patient is eligible for electronic issue must be assessed and controlled using the LIMS. That means there shouldn't be any manual input. Now, let me explain what I mean by this, okay? Now, what happens is that if you test a patient, let's say you're using telepath in your place of work, or maybe you're using Meditech. Once you run a patient test, blood group and antibody screening, if the antibody screening is positive, that LIMS will never allow you to do electronic issue. That is the way it is controlled. So the LIMS is programmed that this is when a patient is eligible for electronic issue, and this is when a patient is not eligible for electronic issue. So the list is programmed to know when I see a history group, I see a current group, the patient does not have any history of antibody, the LIMS will allow you to perform electronic issue. You see it now? Automatic. You don't need to do anything. It does the way the LIMS is programmed. You see it now? However, if the patient, let's say somebody is eligible for electronic issue today, but next week the person develop antibody. Once you run that patient sample and there's antibody screening positive, as soon as you report antibody screening positive, the LIMS will know that there's antibody now because you've reported that this person has antibody. The LIMS is programmed in such a way that once there is a history of antibody, the person should not be eligible for electronic issue. So the LIMS will start prompting you for asking you questions about it. Now, let me give you an example. Let's say you identify antibody big C. If you want to issue a blood electronically, it will tell you this blood is not typed for antigen C negative. As it can prompt you, it can give you an information that will prompt you to know that because this person has antibody, it will no longer require electronic issue. You have to do a serological cross-match. So this risk has to be assessed on the LIMS. That is what the BCSH guidelines said. So that is why MHRA said where electronic issue is performed, it must strictly adhere to the electronic issue guideline by BCSH guideline, meaning that it cannot be supplemented by manual check. And of course, the LIMS is then validated. Remember when I said they are programmed, that's what I mean. So you have to validate the LIMS to be able to do that. Remember that these very LIMS, they are just a software. So that is where the IT comes in again. We'll come into that, okay? But that's where the IT comes in, because in working together with the IT, these LIMS can be programmed to do this thing. They can be validated to do this. So the LIMS is the one that will determine if the person requires electronic issue or does not require electronic issue. And that risk will only be assessed by the LIMS, cannot be supplemented by a manual check. And that is why the LIMS will be validated to know if there's a historic blood group, there's a current blood group, no antibody history, electronic issue, the LIMS will allow you to do that. But if there is no historic blood group, or if there is no current blood group, the LIMS will not also allow you. You see it now. Even if there's no history of antibody, if you do the blood group testing and you get a blood group and the antibody screening is negative, but this is the first time you are testing the patient, meaning that is a historic blood group. You see it now. even if the antibody screening is negative, the LIMS will not allow you, because the LIMS has been programmed, validated, that for someone to be eligible for electronic issue, there has to be a historic and a current blood group. You see it now. Now, even though there's a historic and a current blood group, if there's a history of antibody, the LIMS is also validated to let you know that once a patient has any antibody, the person is no longer eligible for electronic issue. So this is our program. That is a guideline by BCSH, in terms of electronic issue. And that is why MHRA said when electronic issue is performed, this guideline from the BCSH, has to be strictly adhered. Okay? Another guideline they mentioned is this. Before I said it, in fact, I kind of call it remote electronic issue, meaning that sometimes a laboratory can actually issue a blood to another hospital, meaning that a laboratory in a position A can issue a blood that will be used in another hospital of position B. So, and that is a remote electronic issue. It's where there's a physical separation from where the blood product is issued and where the blood product is used. So they cover this, MHRA covered this, because it can be a concern. It's not every hospital that has a blood bank. Don't forget that. So if they don't have a blood bank, does not mean that they cannot transfuse someone blood. You see it now. So when someone in that hospital needs blood, they may have an agreement with another hospital that can supply them this blood. You see it now. So that means MHRA also covered that, because that can be a risk. You see it now. There can be a risk. And because there can be a risk, they have to cover that. Imagine I issue a blood from a position A, from a hospital A for hospital B. I don't know what happened there. You see it now. That can be a risk. And because of that, MHRA covered that. So, yeah, remote electronic issue. That's another guideline. So, what does this guideline say? This guideline is looking at the fact that because there's a physical separation from where the blood, is issued and where the blood is going to be transfused, they covered it. So, there are two key things that is listed in this very guideline. Number one, allocation/reservation. Talks about, either that physical place where the testing occur, or where the blood is also issued. What it means is that this particular hospital, have gotten a request from this other hospital that don't have a blood bank. So when they get that request, so this hospital that have got that blood bank will do the testing, for example, do the blood group of the patient, okay? Now from that, they can actually do electronic issue if the person is eligible. When they do electronic issue, they need to do something else. We'll come to that. But I'm going to say that allocation/reservation talks about where the sample testing occur or where the issuing of the blood occur. Does that make sense? Also, it can also refer to where the blood storage is, okay? Meaning that this hospital that will do the testing and everything, they have this blood, okay, where they store them. From there, they can do the electronic issue, then send to this other hospital that does not have blood bank. You see it now. So the risk is covered. Anyway, I'm trying to say that in this very remote electronic issue, you have two keys there. One, allocation and reservation, which I've explained. Then the next thing you see is the next key, which is the number two, is the issuing. So in the issuing, now I want you to know that, so the allocation and reservation, I've explained it. In the issuing, which is the number two, what then happened? So you've done the testing in this laboratory or hospital that has blood bank. Everything that happened on site of people that have blood bank will also happen when it comes to remote issuing or remote electronic issue. What it means that even when the person get a request from another hospital, if you know that this patient has a historic antibody or has antibody, you have to do a serological cross-match before issuing them any blood for that patient. Okay, so what am I trying to say is this. So when it comes to the issuing, what the guidelines say, even if you do a serological cross match, it doesn't matter. Even though I call it remote electronic issue, it can also be remote serological cross match. For the fact that you are issuing a blood from this hospital to another hospital, there is something you must do. You have to make sure there's a clearly labeled of the patient that should have that blood or the blood product. Okay, you have to print out the label. Okay, basically when you issue it in a patient name, let's say you issue it to a particular patient that is Mrs. A. So that Mrs. A, when you print out the label, it will bear Mrs. A, the date of birth, the NHS number, the hospital number, whatever the detail, the blood group of the patient, all the detailed information will be there, and you tag it with that blood before sending it to that hospital. That way, when they receive it from that hospital, they are not allowed to transfuse that blood to any patient until they've confirmed that the patient they want to transfuse the blood to, the label on that that you've tagged that blood with has the patient detail. That is what the guidelines say. You see? Okay? So now I've mentioned the allocation and the reservation and the issuing. So in the allocation is the testing, that is where it is physically separated from where the blood is going to be transfused. Okay? So the testing part of it, or where the blood is stored, then the issuing talks about you make sure that you label everything correctly, like I've said, before issuing that blood to that patient. Okay? And those people receiving it, they should not transfuse that blood until the label corresponds with the patient that they want to transfuse that blood. Okay? And that means that they have to be involved. That means when we're doing this, then when they make a request, when they make a request in this hospital that does not have blood bank, and you should be able to receive the request in the hospital that has a blood bank. In other words, there has to be a link. There has to be an interface link. I'm talking about IT now. This is where I'm going to end this, because next time we're going to talk about the IT. So you're not going to now look at the link, the interface link between this hospital A or B that does not have blood bank and this other hospital that has blood bank. You see it now? So that interface has to be there. There has to be an agreement so that whatever thing that is happening, each other can be able to see it. So anyway, here you go. That is what happened when we talk about electronic issue or serological issuing of blood, guideline from MHRA. Okay? So yeah, that's what happened. So, and again, remember, in addition to this very interface, there has to be communication between this hospital, that is requesting for the blood and the hospital that is going to be issuing the blood. They should have a means to communicate to each other, okay? Anyway, this whole thing are the guidelines just to make sure that we limit any possibility of errors, okay, when it comes to remote electronic issue or serological issuing of blood, okay? So thank you guys so much for listening, and please, if you do have any question, put it on the comment section and let me know what you think about the video. So next time we're going to be looking at MHRA IT guideline. I'm sure that you already have a clue what I'm going to be saying, okay, about the IT. We have indirectly mentioned the IT, but I'm going to make it a video on its own, okay, so that we can also dive into many examples, okay? Yeah, here you go. And thank you guys so much for many of you people have been sending me message on my LinkedIn on how my video has been able to help you to secure a job. Thank you so much. I want to also advise you to continue to listen, because the videos really, they are not about getting a job only. It's also about practice. You are going to need them to be able to practice effectively and make minimal mistake, especially at the early stage, okay? You don't want to make an obvious mistake that will make you feel bad. And if you stay close to this very channel, you are going to learn so much, I promise you. Anyway, thank you guys so much till I come back your way again. Bye-bye.